Okay, so
We are now live.
I see that we have a wonderful representation joining us from across the state. And I think most of you know me by now. I started this project on my desk working for the director of the California Department of Managed Healthcare as a regulator. And when I saw the publicly available data for blood pressure, cholesterol, and blood sugar, I was very moved by it and reached out to the deans of UC Berkeley and UCLA Schools of Public Health and asked them to collaborate with us on improving the performance in California. Next slide, please. So I want to thank all of our amazing leaders from across the state, from San Diego all the way up to Lake Tahoe. We have people joining us today, and wonderful supporters from all of the major universities of California, the California chapter, the American College of Cardiology, the State of California Department of Public Health, the Los Angeles Department of Public Health, UC Berkeley, of course, which is now the mothership of the Right Care Initiative, and that is where I work. And we have our wonderful pre-med model where we train up future leaders in healthcare through this work. And I also want to thank the biotech industry for their consistent support since 2008. Next slide, please. So Dr. Baumer is our statewide chairman, and he has been leading our work in the Capital Region, not only to inspire the other healthcare leaders to better performance in that region, but also with our partners in state government, and he also works on legislation. So with that, I'm going to turn the meeting over to our fearless leader, Bill Baumer, who trained many of the cardiologists in the state of California. And welcome, Dr. Flynn, and thank you to Blue Shield of California for your support.
Well, thank you very much, Hattie, for your leadership, and welcome everyone to the Right Care Initiative. I wanted to go over 2 or 3 items before we get started on today's exciting program. So the California Right Care Initiative focuses on a couple of simple things, 3 simple things. We try to get blood pressure controlled, we try to get cholesterol controlled, we try to get diabetes controlled. And by doing that, as well as lifestyle with medications, we believe we can significantly reduce cardiovascular risk throughout California. So our ideal is to get to 0. It's a long ways to go, but this is at least a start for that. Next slide. So we do monitor throughout the healthcare providers of the state of California in the 4 counties we're in, Sacramento, LA, San Diego, and Santa Clara, the performance. And the idea here is not that there's a variation in the yellow bars or performance. The idea is we're trying to get all of these control levels above 80%, better than 80% control of blood pressure, glucose, and cholesterol. So we will not be happy until we get them higher. And even though there's a variation here, the idea here is to get all of them, and all of us need work to do to get there, above 80%. And hopefully in the future, we will be able to show you a very boring slide with just yellow bars across all areas for Northern and Southern California. Next slide. So we do that by a number of ways, our goals, by trying to get those things down. We use a collaborative process, of which today's team meeting is part of that, involving clinical pharmacists on the care team, patient-centered practice design. So we make changes in how our practice works for that. We do follow national guidelines, which are very important, and protocols, which help us and our healthcare providers achieve better care of their patients. Next slide. Today's program will be participated with some of our co-chairs shown here, Doctors Ivy, Kaplan, Stock, Vora, and you, who are in the Bay Area. But we have other co-chairs from San Diego, from LA, and Sacramento as well. We want to welcome them as we look forward to an exciting day today. I think about advances and challenges in treating women's cardiovascular disease with Dr. Noelle Bairey Merz and advancing stroke prevention with Christina Mijalski. Next slide. So why are we focusing today on women's cardiovascular and cerebrovascular disease? Well, you would think that women probably have a similar risk as men, maybe. And actually, in some cardiac areas, their risk is even higher. Showing here is an arrhythmia that is associated with sudden death. You can see the red bars here with the arrows. Women have twice the frequency of having torsade de pointe, which is a risk for sudden death. So they're at actual higher risk than men in this particular situation. Next slide. So we would say, well, if women are similar or even sometimes higher risk of cardiovascular events, I'm sure they're well studied in all of our trials. Well, if we look here on the left in blue at the arrow, we can see for some types of diseases like infectious disease and cancer, women are well represented in the studies and information that we have. But when we get to the bottom of the left, we see for cardiovascular disease, their representation in reported information is only 20%. So it's really on the low side when we get to cardiovascular disease in reported information. And if we go to the right side of the slide, if we look at the participation of women in clinical trials, you can see women at the arrow shown in red are seen in many trials, but when we get to the bottom of cardiovascular disease, you can see that the red bar for women trials involves only about 30%. So again, they're on the low minority of that, even though their risk of disease overall is higher than 50%. So the most likely risk gets the least studied at this point in time. Next slide. And so just to show you a topical, it's still current. This is a trial that came out this last month. And what it showed in a large group of individuals, 147,000 veterans with existing atherosclerotic disease, meaning they've already had heart attacks. Women were present in 7% of those under 55 and a higher 14% of younger women under 40 years of age. So younger people, women are well represented in already having had a heart attack or existing cardiovascular disease. And despite the fact that they are well represented in having disease, they're much less likely to receive adequate treatment. You can see their chance after they've had a heart attack of receiving what may be life-saving antiplatelet therapy was less than half of men. And for statins, again, was 40% lower than men. So not only are they underreported, not only are they in fact understudied and represented in trials, when we get to treatment, they're now undertreated for disease. So this represents a significant problem that we have today. And the conclusion shown on the bottom is that in this study, women veterans who all have access to healthcare, so it's not that they don't have healthcare, women veterans with premature and extremely premature atherosclerotic disease, that is women having heart attacks before the age of 40, receive poorer secondary prevention, i.e. treatment, and hence a systemic approach towards healthcare delivery improvement and education are needed today. And that's what brings us to our presentation. Next slide. Today, that will be led by Dr. Noelle Bairey Merz. And there's more awards and honors than I could ever read in this period of time. She is the director of the Barbara Streisand Women's Heart Center and director of the Linda Joy Pollan Women's Heart Health Program and Preventive and Rehab Cardiac Center and Cardiology at the Schmidt Heart Institute. So she has a variety of interests encompassing every area, I believe, of women's cardiovascular health. As we look down there, she's been the chair of many trials, which are pivotal trials reported in the United States, NHLBI sponsored for that in a variety of areas. And she has served as the primary investigator for many of these trials. She will be presenting that information and that background and that information to us today. And we look forward to a delightful afternoon with the world's expert on women's cardiovascular health, Dr. Merz.
Oh, thank you so much, Dr. Baumer. That's a very generous introduction. And I'm delighted to share with this group a presentation. And now, of course, I have to fix it because we practiced. Let me get this up. There we go. Thank you again for this focus and emphasis on women's cardiovascular disease. I have aimed here to not only tell you about knowledge that we have now about the importance of what we call sex-specific physiology and pathophysiology. Men and women are different, and sometimes it matters. But I'll hopefully tell you also what I think we can do as a group. And I love this initiative. So thank you for including me. These are my disclosures. They're essentially all research, with the exception of I do serve on one for-profit board, not related to the topic today. Well, what are some cardiovascular disparities and how do they impact prevention, the goal of this group? I'll share with you what we call an epidemic of death in women. We did start to get some attention to this topic. We'll talk about gender and secondary prevention, which gives us some cues about gender and primary prevention. And again, with a focus on women, but we'll talk about sex differences when it's relevant because some of the treatments don't differ, and that's important. Last but not least, policy in our future. So I thought I'd try to see how much an audience already knew. These are questions that might be on a board exam, might be something that you would teach your medical students or even your allied healthcare professionals. And then I'll hope to educate you and you can see if you got the right answer at the end. So following a heart attack, aged 50 and younger, women are more likely than men to die, less likely to die than men of the same age, or equally likely to die than men of the same age. So young women. So let's go forward and look at the data. This is where we experience this epidemic of death, cardiovascular death of women. Back in the 1970s, more men in the blue bars were dying compared to women. But something happened in the 1980s, and in 1984, the curves crossed for the first time. So as a country, and this is adjusted for prevalence, meaning the population, there's always a few more women, 51%. But genuinely, more women were dying of cardiovascular disease than men. The curves continued to separate, and we started to describe this. We had our director of our National Institutes of Health who called it the Yentle Syndrome. And remember, Yentle was a woman, Barbara Streisand, who wanted to have all the rights and privileges of a man. She wanted to be able to get educated, so she impersonated a man. So the idea was that maybe we weren't recognizing women because they didn't look like men. And it wasn't until the late 90s that our National Institutes of Health, our American Heart Association, our American College of Cardiology kind of got on board and said, hey, this is not just a random accounting error. This is bad and it's getting worse and we know nothing about it. The joke, if you find this funny, is that this 12 years, if it had been anything about erectile dysfunction or the prostate, it probably would have been a lot faster. But at least we came to our senses and decided to do something about it. And so these are our two leaders who were talking about this in the 1990s. Dr. Bernadine Healer at that time was our director of our National Institutes of Health. And she referred to the movie that had come out at that time. And on the right, as you can see, Barbara Streisand in that movie, The Yentle, dressed up like a man so she can attend school and become literate. Of course, it's, a love story and it's got all these great songs in it, but we don't have time for that today. So what happened when we were first asked to study it? And Viola Vaccarino, one of our WISE investigators, published this quite early. This is 1999 in the New England Journal of Medicine. And that either seems like a long, long time ago or not that long ago. But this was a huge wake-up call. The data had never been sex stratified before. So for the first time, we recognized that more women were dying than men in the setting of a heart attack. They got to the hospital, they were having and diagnosed with a heart attack, and more women than men were dying. And the first explanation, of course, was that it was old women, but it wasn't old women. It was young women. It was younger women under the age of 50 that were more likely to die than a 50-year-old man of their heart attack. And that was stunning, completely stunning. So largest mortality gaps were in young women. Now, one of the things that happened early on is National Heart, Lung, and Blood did a pretty good job and said, hey, there's something different about young women. And let's get a bunch of people in the room that know something about women's heart disease. And I and other people had those few publications. And they said, let's see if we need to fund something. What should we fund? And so one of the first things that we did as a group was we looked at all of the existing data sets that we already had about heart attacks. And heart attacks, in another term, is sometimes called acute coronary syndromes. And then they're stratified by things like unstable angina and MI with ST segment elevation, that's a heart attack, without, and then there's with. And this is at risk, this is moderate risk, this is very high risk for death. And what we demonstrated, and again, no one had looked at this, was that with acute coronary syndromes, 1 out of 3 women, their arteries were completely open. And we had this idea that we knew what caused heart attacks, plugged up arteries. In fact, we had treatments for that, bypass, angioplasty, stents. But 1 out of 3 women you couldn't treat that way. And this was as high as 10% in these very, very severe heart attacks, compared to almost half of that in men. And when we looked at this and we would go talk to our cardiology colleagues and they would say, well, the open artery heart attacks, that's not common. We said, well, you're just looking at the men. You're not looking at the women. Let's look under the hood. What's going on? How can women have heart attacks with open arteries? So this was our first 5 years of funding for what eventually became the Women's Ischemia Syndrome evaluation. But what we and others demonstrated, and these are some registry data, is that women and men develop these what are called acute coronary syndromes. Everybody goes up to the cath lab. Men have these plugged up arteries. These strictures are plugging up. Women, on the other hand, have something you can't see unless you look specifically for it, and this is small vessel disease. And what happens is, because we all recognize the plugged up arteries, that's the pattern recognition that cardiologists are all taught, more men receive the treatment, because now we can make a diagnosis. Yep, that's the problem. And then we put them on these life-saving pills. Just like Barbara dressed up like a man, she looked like a man. She got to be educated. So if women they live long enough to look like a man, they get treated. Here again, Barbara looking like a woman with her husband, much less likely to be treated. And then more women die, because if you don't treat a heart attack, the death rate will be there. We've known that for a long, long time. That's why we develop treatments. So for this epidemic of death, in summary, there's a significant adverse gender gap in coronary heart disease MI mortality, and it exists to this day. We've narrowed it, I'll show, but we still have a gap. Women, particularly younger women, face this more adverse prognosis, and our worst group for the increased death is under 50, which is young. Adjustment for disease severity, comorbidity, and treatment does not fully explain this gap. So let's talk about gender then in secondary prevention. That means after the heart attack, and somebody has shown you they have cardiovascular disease, how are women and men treated? So here's a very big registry. It's a little older, but it was selected because it was 40% women, which is a little unusual. A lot of these data sets are 10 and 20% women, and they are not representative of the leading killer of women. And so what you see is that women have often more risk factors, often because they're older, but they're less likely to get all of these life-saving therapies. And needless to say, they're more likely to have increased rates of death, MI, and heart failure. And the secondary prevention pills are these 4 magic pills. That's what I call them. They're guidelines pills. So they're low-dose aspirin, beta blocker, an ACE inhibitor, it's a blood pressure heart failure drug, and statins. Those are the cholesterol-lowering drugs. If somebody is placed on those 4 pills at the time of discharge, the likelihood that they will still be coming back and seeing their physician in clinic is over 90%, meaning this is very effective therapy. And it's cheap, and it's generic, and it's well tolerated. So secondary prevention really works. Now, are the women not being treated because it doesn't work in women? No. Look at these hazard ratios. They work equally well in women and men. So that's why I said, sometimes we just have to compare men and women. The sex difference is then the disparity or the gap. Well, there's no justification for this gap, that these drugs, the 4 magic pills, work equally well in women and men. So we need to get on the stick with these guidelines. Now, here's data that's even more contemporary, and 25 years into working on this and describing these disparities, here's where we are. Both men and women had a heart attack on this figure. And so we're looking at discharge, high intensity statin prescription. So if you've had a heart attack, any of these ACSs, this is a class 1 indication. You would be discounted in any of the quality metrics if you do not discharge the patient on this statin. 1 in a million will have an anaphylactic reaction like penicillin. So you're off the hook for 1 in a million. But other than that, you've got to prescribe these drugs. So what you can see is that women and men, solid and dotted lines, are comparable, but the women are almost always lower. And the women are equally likely to have guideline high intensity, but less likely to give any statin. So the few that get the high intensity, well, it's not few, it's pretty good, but we still have this disparity. And we don't have a good explanation for it. It's not because the women refuse. And it's probably something about putting women up on pedestals and just saying that they can't take strong medicine, which is kind of goofy. But here is also more data talking about coronary heart disease declines in the United States, more data from Viola Vaccarino's group. demonstrating that male mortality for these young 25 to 54-year-olds is on the decline. Women is not. These young women, we are not getting to them. And everyone else, the older women, it's going down. So we're doing a pretty good job with some of the guidelines. In the intersect between female, gender, and race, ethnicity, is particularly bad, adverse for women that are non-Caucasian. So these are data from New York State demonstrating that if you were a non-Caucasian woman, Black, Brown, Asian, etc., Pacific Islander, rates are actually going up. So this is not good. And I'm going to show you some pandemic data in just a minute that also is alarming. So death rates are actually rising in non-white young women. So one of the things that was a big push in the cardiology community, the American College of Cardiology in particular, was guidelines management and really working with the cardiologist, with the hospital, with the health system, particularly with the electronic health record, that these guidelines, these 4 magic pills, were just drilled into, and they would be automatically prescribed unless the doc deselected them. And, you know, there are situations where you don't want to prescribe this pill or that pill. A patient is allergic, a patient doesn't tolerate it, a patient has asthma, etc. So here's data from not us, a different group. Always love to see other people looking at this. And they're a little hard. This is not a great graphic. So I color coded it for you. So everyone had an acute coronary syndrome. And this is just showing the survival after an acute coronary syndrome. And again, remember the 4 magic pills really improve survival after initial heart attack. So the red bar shows that following guideline implementation, mortality improves for women and the sex gap narrows substantially. Now, the mortality for men didn't improve. Why is that? They were already getting treated. So one of our first take homes is that these guideline campaigns with these drugs that work equally well in women and men, we just have to get people to do guidelines. We don't have to have special female guidelines. We don't have to have special considerations, a little asterisk down at the bottom. We just have to treat everyone. Now, the blue bar tells you that there still is some difference, even if we deployed guidelines equally for women and men. And that's where there still is some sex-specific pathophysiology, and I'll address that a bit as well. So there's a reason to continue to do research. This is not all sealed up with the guidelines campaigns. All right, to summarize this second block, gender and secondary prevention. Acute myocardial infarction, AMI, and ACS guidelines therapy work equally well in women and men. The application of these guidelines preferentially saves women's lives. We're doing pretty well with the guys. So can't we routinely deploy guidelines to save women's lives? And that's, you know, the grist for this group. So let's talk a bit now about gender and primary prevention. It's all kind of one disease, but the risk differs for primary versus secondary prevention. So here's another question. The number needed to treat, which is a metric that we use when we do randomized controlled trials to tell us as a society, as a policymakers, as health systems, what's the bang for your buck if you deploy these strategies. So the number needed to treat magnitude for primary and secondary prevention of cardiovascular disease for statin therapy is similar for women and men, higher for women than men, lower for women than men. All right, let's see what we think. So coronary heart disease mortality among young adults, this is primary prevention, definitely has demonstrated that, number one, we have a leveling off of the mortality decline. We've declined, and there's a lot of contributors to this. There's a lot of chat now about social determinants of health. The widening of the income gap, the issues of, you know, insurance, health insurance. So that's bad. I mean, we're going backwards where most developed countries are going forwards. But it's actually an increase in mortality for women 35 to 54 years old. And so women, of course, are the disparity is so bad that it's actually mortality is going up. Here are mean total cholesterol levels for adults aged 20 years and older. Let's, again, stratified by age for both men and women, cholesterol levels have been falling. And why is that? Because over 60, and particularly over 65, everyone has Medicare, and the primary care physicians have done a very good job of handing out statins because these folks are at risk. Age is the most important determinant. But here's what's happening. In men, 40 to 59, it's also gone down in the age of statins, very little in women. In 20 to 30-year-olds, maybe a trend down. 20 to 30-year-old women, it's going up. It's going up. So no wonder our young women are having heart attacks. And again, this is probably because of a reluctance to address cholesterol and blood pressure in these relatively young women. There's the perception that they won't get heart disease, and that's just not true. All right, number needed to treat. So here's a big meta-analysis about statins. And this is meta-analysis of statin therapy in women. You can see the size of the box is proportionate to the number of people in the trial, and particularly these are the number of women. You can see that thankfully older trials had relatively few women, but we had a couple of big trials and we had made the case that we needed to treat women for primary prevention, young and old. And as it turns out, hazard ratio is very strong for benefit, very strong for benefit. This is, this beats pretty much anything you can do to prevent a heart attack or stroke. So here's the number needed to treat. If you aggregate women and men, you have to treat 25 to save one life. That's considered very beneficial, particularly because statin therapy is so cheap, so affordable. There are grocery stores in other states that give this therapy away for free if you'll come in and shop and spend some money on groceries. So that's how cheap it is. And super cheap at Costco, Rite Aid, CVS. And when you look at the difference between women and men, it's really not that different. So the number needed to treat is very much within the range of what we would consider good policy and good return on investment. Yeah, good. All right, the intersect again of racial and ethnic disparities is something that we are increasingly recognize. And this combined with the systemic racism that has been now clearly identified throughout our society, throughout our health system, despite physicians feeling like they're not racist, it's systemic racism. And as my good friend Carol Watson says, it's not enough to say that you're not racist. We all have to be anti-racist. We have to be progressive, and we have to take active steps to help our health systems be anti-racist. Because, just like our vaccinations, if we don't reach the people most in need, we will not help them. And as a society, we will continue to have this horrible pandemic. We will have this horrible epidemic of cardiovascular disease. Women continue also to suffer disproportionately, likely for issues of misogyny. And when we look at society and we talk to anthropologists and sociologists, it's very clear that women are viewed differently from men. And women in particular are viewed objectively, meaning what their appearance is. And women are much more likely to be fat shamed. Both themselves, they shame themselves because they live in society as well as society. And physicians in particular pick on women a lot more about their weight than they do men. And this was shown very clearly in this Virgo study. So the Virgo was a registry matched young, under 50 years, myocardial infarction, heart attacks in women and age matched men, demonstrated that the women were more often diabetic. The women were less often dyslipidemic, although this wasn't due to measuring their blood cholesterol, it's just whether or not they were treated with a statin. We already know there's a disparity there. And they were billed as being more overweight by the chart note saying that the physician had told her to lose weight. But when they were weighed, they were actually less overweight compared to the men. So the problem with this and the editorial that we wrote is diabetes is a more potent risk factor for women. It is. It's twice as potent for heart attacks compared to men. Why are we not? And it's a guidelines. It's a class 1 guidelines indication for giving them a statin. Why are they not getting statins? And then this whole idea of, oh, well, you know, maybe if you lose a little weight, you won't have to take the pill. And it's like, wait a minute, that doesn't make sense. Completely not guidelines. And losing weight doesn't lower cholesterol. And the women were less overweight. So we also have to be careful. And, you know, I'm sort of an advocate. We have to talk about this. We have to talk about misogyny and sexism. And in a nice way, just like racism, we have to be anti-sexism and anti-misogynistic. This is the cartoon that I tried to get published with the editorial. And I was told by the editor of this high impact factor journal that this would be disgusting for his readers. Yeah, okay. I'm a little provocative, so.
Well, we'll put it on our website if you put that together.
All right. We actually did a large national survey. This was part of the Barbara Streisand Women's Heart Center, and part of the endowment is dedicated to policy work. And so we actually did a national survey of community residing women. It was representative. Women that did not have smartphones or computers were provided with those to be able to take the survey. And then we had a nice mix selected and randomly of primary care providers as well as cardiology physicians. And you know, there's a lot of detail on this slide, and I'll refer you to the publication in Jack. But you know, the sad reality is in this contemporary day and age, half of women still don't know what the leading health threat is. More women will die of cardiovascular disease than any other, including all cancer combined. And that they often deferred doctor visits in order to lose some weight. So see, they don't want to go in and be told that they're fat. Nobody wants that. But they should go in and be told, oh, let's take care of this blood pressure. Oh, by the way, you're diabetic. Let's take this statin pill. And oh, by the way, let's talk about your exercise routine and sitting last. We also had good news from our physicians where many of them said they did not feel educated about how to take care of women's heart disease. And they asked for educational materials, which were, again, as a policy, we are working on that. I threw in a couple slides about COVID. And here's what we're anticipating. Of course, and this just came out in JAMA last week, our first wave of death. And we definitely have had excessive death. It was 2/3 of it was COVID. Another third was missed heart attacks and strokes, died at home because they didn't come into the emergency room, and then overdoses, alcohol and narcotic overdoses. And we know the story behind that. So the pandemic is more than just COVID, of course. The second wave here is the folks that survived their heart attack and stroke, or they needed their aortic valve placed, but they have deferred it, or they had a positive colonoscopy, but they deferred their cancer surgery, and now they have metastatic cancer. And so we're going to see that as well. And we're starting to see that now in the medical center. But the third wave is going to be cardiometabolic disease. Here's why. Pretty much, if you average, the population has gained weight. and not small amounts of weight. And I have a couple of patients, maybe 10%, that actually lost weight because they didn't have a commute. They had more time to exercise. They were more attentive to eating. They weren't eating out as much. But most people gained weight. So to offset those people that lost weight, the people that gained weight probably gained even more. So we are going to see this. And what happens, of course, with atherosclerotic cardiovascular disease is it's like laying down rings on a tree. So we won't be able to get rid of this. And this will be a trajectory, a pandemic related trajectory that is going to increase cardiovascular disease. These are the Kaiser Family Foundation data that demonstrate that women, more likely than men, were more likely to skip preventive health services, skip a recommended medical test or treatment, again, during the pandemic. They'd drive the husband in, but they wouldn't do it for themselves. And this is another cultural barrier. Women take care of the kids, the husband, the dog, and then finally, she's going to take care of her own health needs. And these are policy issues as well. How can we break down those barriers? How can we make it more convenient and affordable? So gender and primary prevention. Primary prevention works equally well in women and men for CVD. We're real big on these ASCVD risk scores. We're increasingly embracing the coronary artery calcium scores. Guidelines are out there, we should use them. Act on the scores, not on intuition or physical appearance. If you do these calculators, you'll see that body mass index, body weight, BSA, it's not in the predictors, doesn't predict disease. Might predict diabetes, but it doesn't predict heart disease. And then be prepared for a post-COVID CVD epidemic. All right, we're in the home stretch. Women with diabetes or similarly elevated CVD risk are more likely to be treated with a statin than men of the same age, less likely to be treated with a statin, equally likely to be treated with a statin. You probably know the answer to this at this point. So here's clinical practice guidelines. And for a while, we were sex stratifying guidelines. And then the data came that, these drugs work equally well in women and men. There are some differences, but, we should just be doing guidelines. And here's the outcomes. This was not a randomized controlled trial, but you're never going to get that kind of data. So here's what happens when you deploy guidelines. 97 through 2007, a decade of guidelines, we saw cardiovascular disease decline 43% in women. The men kept going down. We were doing a good job for men as well with these guidelines, right? So we're pretty happy about that. But here's the truth and reality of what's been going on. And I shared this with you earlier. Male mortalities stopped declining. Women's mortality is going up. And the 30% decline initially, and now it's going up. And again, a lot of this is social determinants of health, societal issues that we may or may not be able to address, but we really need to do what we know works, which is these guideline campaigns and the rest of your group. All right, why am I not going? There we go. Okay, so policy in our future. We continue to advocate for investigation. Look at, the National Institutes of Health return on investment. For every $1 we spend in research, we get 10 back in terms of years of disability lives saved. So we must continue to do this and look at what was really kind of a miracle, but you know what, this is science, it's not a miracle. The Moderna and the Pfizer vaccines, boom, in under a year. So if you give the scientists a goal and some money, they'll do it. Educate, we are advocating and working aggressively with the AAMC, with all of the boards for test questions. And this is what the docs asked for. They said, we need more education. And as you know, teachers teach to the test. So if it's on the test, you got to know about it. Translate, continue to do guidelines work. And we were talking a bit about that in the beginning. We need some coronary artery calcium score data for guidelines. And then we have to advocate. We have to be anti-racist. We have to be anti-sexist. We have to have policies that are progressive and addressing these disparities. This is our benefactor that established our endowment and raised funds to allow us to do a lot of this work. The research, of course, is funded by the National Institutes of Health. And I might stop there. I had a few more slides, but I can see that I'm just up on my 50 minutes of time, and I don't want to not be able to take Q&A. Thank you.
Could you quickly go through your slides, and then we'll hear from Dr. Steve Sidney, who has his hand up.
Okay, so just do these remaining things. Okay, is that what you meant, Hattie?
Yeah.
Okay, very good. Okay, well, here's a little more of the things that we're doing with policy. And this is a joke slide, of course. You know, the doc says we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men, but medical research in women, this never occurred to anyone. So here's a dated, but it is in the process of being updated, that women in randomized controlled trials of cardiovascular disease, and it compares the number of women that are in the trials to the prevalence and to the deaths. And you can see that every one of those gray bars is lower than the white and the black bars. So why do we continue to allow women to be underrepresented? And a lot of this has to do with trial design. And it gets back to Barbra Streisand. And when she looks like a man, she gets into the trial. And when she doesn't fit the male criteria, you don't get into the trial. So it's not that women don't want to go into trials. We have lots of studies that are women only, and we've had no trouble enrolling. And these are the most important ones. Women are less likely to present with obstructive coronary disease. We talked about that in the beginning. So no wonder they don't get into ACS trials that require that you have a lesion that you can throw in a stent. If you know, you're going to test stents, you have to have stentable disease. The VA CART data now show in men, the Veterans Administration, that this ACS with open arteries is now a male problem as well. So we need to know more about it. Women can't get into a trial that require a positive troponin when we use male standard troponins. So men and women on average, women are smaller than men. On average, women's hearts are smaller than men. On average, women's troponins are lower than men because of those reasons. And so when we use a standard threshold to say that it's abnormal and therefore you're having a heart attack, we miss women. So this study done in Scotland, very elegant, used a high sensitivity troponin and just used a different threshold. And what they demonstrated very clearly was that the women that were having heart attacks by a lower threshold, but sent home because they didn't meet the male standard, had a 25 to 35% one-year death rate. This is the death rate for heart attacks when I was a medical student. And now it's less than 5%. I mean, if you can get to the hospital, we don't let you die. So that's crazy. Back to the 1970s mortality for women. So, and we can do a better job with men as well, small men. Here's the heart failure data. Women have been understudied for heart failure because they're more likely to have heart failure with a preserved pumping function. It's a different form of heart failure. And we know very little about it, and we have no proven effective therapies, again, because of our lack of study of women. This is one of our policy slides published in JACC recently. And it just demonstrates that we have a lot of avoidable morbidity and mortality in women. And it just walks you through what we need to do. You know, it's patient-centered care. We need to have community standards and policy. We have to reduce barriers. We have to recognize that some of these unique clinical situations. We always want the innovative research, and we want the health system redesign, healthcare for all, and maybe more telemedicine because it's kind of easier. It's getting around some barriers. Women's cardiovascular disease remains underfunded if you were to proportion it to the burden, disability, morbidity, and mortality. And it's particularly painful for us because this is the money spent on women's heart disease at National Heart, Lung, and Blood. But if you walk right over to the National Cancer Center, it's a pittance of what they spend on women's cancer. Breast cancer, ovarian cancer, endometrial cancer, the bikini cancers. And so we really have to do better. I mean, this is not okay. No wonder women are dying. All right, last question. And now you get to see if you thought, this isn't the last question, this is a repeat question, if you got it right. So following a heart attack, women age 50 and younger are more likely to die, right? Did everybody get that right?
Yep.
I gave you the answers. Younger women with diabetes or similarly elevated risk are less likely to be treated with a statin. Got to use our guidelines. Ignore what they look like. The number needed to treat, magnitude for primary and secondary prevention of cardiovascular disease for statin therapy is similar for women and men, works equally well. Okay, so now here's my real final slide. Thanks for letting me finish. And that is my email. I get lots of emails and I'm always delighted to get them. And then that's our website. If you want to see our research, our advocacy, our education initiatives, and it's just us. There are other places doing fabulous stuff. So I'll close with that and thank you for your attention.
So we have Dr. Steve Sidney with us from Kaiser. I think you probably know him. He's done such amazing work on the early cardiovascular disease and coronary calcium. So I think your paths have probably crossed. Steve?
Know of each other, yes. Mm-hmm.
So that was a wonderful talk. Thank you. And I think you just pointed out beautifully all the disparities in inequities that women are dealing with relative to men in relationship to cardiovascular disease. I'm kind of a numbers guy, and there were a couple of things I did want to point out. One was that, because I look at mortality data a lot, diabetes mortality went up hugely in 2020. While we don't really have rates yet because we don't have good denominators, the number of deaths increased more than 13%, which is huge. Yeah. And it, it's fits in with exactly what you said about the healthcare, not getting treated well and all of that stuff.
And the tsunami, right? Do you agree with that? We're going to live with this. It's not going to be a one-year thing. Yeah.
Right. The one thing, though, I think probably most people in this room understand this, but I just want to make it clear that heart disease and cardiovascular mortality at any age is still significantly higher in men than in women. And in fact, the decrease that you're referring to, in one of some papers I wrote a little while back, I had identified something that still is the case, that while heart disease mortality had been going down gangbusters really from the 60s all the way through the first decade of this century through 2010, it took a sudden turn around 2010, 2011, and it's almost stagnated. Yeah. So that since 2011, overall mortality has still been decreasing, but only by 6% in that time, if you look at age-adjusted rates. And it's a very similar decline in men and women. But what's also happening is the number of deaths is going up, and it's gone considerably up, and maybe more so. I haven't really looked at this in women, because most of heart disease and cardiovascular mortality is concentrated in older people. Now, you pointed out, those distinctions in the younger people, which are of interest, but more than 80% of the deaths occur in people 65 and older. And if you've, probably a lot of you have heard about the so-called silver tsunami, which basically, if you look over the past 10 years, more than 80% of the entire population growth, approximately that time frame, maybe a little less than that, more than 80% of the population growth has occurred in that age group, the 65 plus age group, even though there's only about 15 million people in that group. So what we have is this huge increase in numbers of people over age 65, causing a large increase in the number of deaths, even though the rates are still going down, albeit not that very quickly, while the under 65 population has nearly stagnated. So I just wanted to make those points that, I think you're right on about everything you say and about all the points you've made about the women. But I do think, a lot of the mortality things are pretty similar in the men than in the women in terms of trends.
Steve, did you have a question for Noel?
No, I didn't. I just wanted to kind of clarify. I'm sorry if I took a lot of time there. Actually, it had my hand up by mistake, but I've been thinking about these things during the call.
We're delighted that you're with us, and we're hoping that you'll work with us and Noel Bairey Merz on an expert process for addressing these issues better, particularly with regard to the young women who are perishing unnecessarily. And I just love your talk, Dr. Bairey Merz. We'd love to have a question from Evelyn Stock, one of our shining star cardiologists from UCSF.
Oh, thank you, Hattie. Well, Noel, what a great talk, eye-opening, showing us this crisis that we had suspected, but it made me want to cry, seriously. I am, but you have inspired us, and now we have marching orders. These are marching orders. We need to get to these women. As you mentioned, the women under 50 are particularly threatened. These are young mothers where there are core of our society, right? And I see these women in my clinic. I do preventive cardiology, and I was trained by one of our leaders in lipid management, Dr. John Kane, whom I saw in the panel here. And we get a lot of these young women who are not treated. And, one of the main things that they mention is what you mentioned, that they are deferring starting as they try to lose weight. Another thing that really doesn't bite well for them is this ratio, HDL to cholesterol ratio, which has harmed so many women. And I want to raise awareness of that. Women who have HDL are not protected, people. They're not. And the main reason is because the functionality of HDL might not be there, right? And Dr. Merz, and they're all seeking fertility. Some of these women seek fertility and delay the onset of their drugs. If you had, in a perfect world, your choice, what would be your perfect intervention or trial if we could give you, all the millions of dollars that you deserve to fund your research? What would be your perfect trial?
Well, as a cardiologist, I'm probably more interested in finding effective therapies for INOCA, MINOCA, heart failure with preserved ejection fraction. I'm not really a public health person, but I would consider, and you and I have discussed, that we have tried to get National Heart, Lung, and Blood to do a randomized controlled trial of coronary artery calcium scanning, and that would be a public health strategy trial. Does it help more than it hurts, right? It's a small amount of radiation. And so I
Such an important.
any of those trials. And one of the things that we have advocated for with some success is female only trials, because part of the problem, and Dr. Sidney, identified it, if we continue to compare women to men, we fail to recognize that there's 300,000 cardiovascular deaths in women every year. And yes, 2/3 of those are elders. And, maybe that's one of the ways to pass in our country. But 20% are in women under the age of 50. So 20% of 300,000 deaths, that's about 60,000 deaths every year, premature mortality due to CVD in young women. It is much more than breast cancer, endometrial cancer, ovarian cancer death. So see, the problem is when you constantly compare it to men, you say, well, men, or there's more men. Okay, there's maybe, 30,000 more men. It's about half. Look at this slide. It's about half. So I think we have to get away from the comparing to men, and I think we have to do a better job addressing the disparity. And then if things were equal, then I'm okay with lumping everything together. Yeah.
Right.
Thank
We
you
have,
so much. Oh.
yes, we have a couple of questions from the audience. Do we still have
Shall we
time?
save them for the end and then keep moving on to Dr. Mijalski?
All
That'd be
right,
great.
we're going to
Thanks.
have
Yeah, so
Dr.
we're going to transition to the stroke topic now. And Dr. Bairey Merz, we are just thrilled to have had you with us, and I hope you can stay.
Sure.
Because we view heart attack and stroke as two sides of the same coin. Maybe we're wrong, but
They're related, kissing cousins.
our
Not
co-chair, Nirali Vora, but she has she's introducing us to Dr. Christina Mijalski cells, and we're just thrilled to have these wonderful young women leaders with us, and we hope that you'll participate with us in an expert process to improve things. I think we need a project brief to be written on women's mortality, young women's mortality, to really emphasize the point that you just made, Dr. Bairey Merz, and I've never heard anyone say it better. I'd really love to do some perhaps editorials with you or something like that. Okay, thank you, Nirali, for taking over here.
Yeah, and thank you. My thanks as well to Dr. Bairey Merz. I think it was a great discussion, and I really appreciate the attention to thinking about disparities in the ecosystem and not just biology necessarily, and not just comparison to men. And we're going to have the pleasure of hearing sort of the flip side of that on stroke, really hearing about women across the continuum. It's my great pleasure to introduce Dr. Mijalski Cells, who's my colleague and dear friend, but also really building her profile here in stroke in women and women across the continuum, including pregnancy, et cetera. Dr. Mijalski did her stroke fellowship at Harvard and joined the faculty at Stanford almost, 7 years ago now, and has really been a leader in building telestroke for the Stanford Stroke Program. She is the director, and to Dr. Bairey Merz's point, perhaps filling some of the disparities by making it easier for women to attend and receive care both in the acute and outpatient setting. And she is also running various clinical trials, writing papers, and really dedicating herself to the quality improvement of acute and long-term stroke care at Stanford. So I'm going to just be brief and move on to Dr. Mijalski's talk. And I hope that we can have a really great cross-collaborative discussion, because there's so much we can learn across from stroke and cardiology helping each other. Dr. Mijalski, take it away. Thanks for being here.
Great, thank you for the kind introduction. I'm just going to share my screen here. All right, So thank you, Nurali. I'm really excited today to talk a lot about treatment and prevention of stroke in women across the lifespan and about how this changes, and really viewing stroke in women as a true public health disparity. And I think what you'll hear throughout our talk today is truly how much of this mirrors all of the cardiovascular disease standpoints regarding inclusion in clinical trials, treatment effects for stroke. We really are seeing the same things on the stroke side, and there's so much opportunity for improvement. So the topics that I wanted to talk about today are stroke epidemiology and public health disparity. I started out in public health at UCLA and then worked at the CDC for a few years. So I kind of approach stroke treatment as a public health disparity. And I think it's important to do so since we really, I think, can agree that women are an underserved population in both cardiovascular disease and cerebrovascular disease. I wanted to review the mechanisms of stroke as well, because your risk for each and the timing of each in one's lifespan changes, and it's important to recognize that for screening and treatment prevention purposes. Age and gender epidemiology in stroke I'll review, and then I'll spend a lot of time on stroke and pregnancy in the puerperium. And the reason is it really is the ultimate healthcare disparity for women when they're understudied and undertreated, because the well-being of the pregnancy is most often considered paramount by most providers. Then finally, hormone replacement therapy, menopause, and stroke is always a very important question that we get. So just to start out with stroke and public health impact, as you know, stroke has a tremendous public health impact in terms of both morbidity and mortality. And we saw between 1975 and 2015 that stroke shifted from being the third to the fifth leading cause of death, only 5.2% of deaths in 2015. And this was a tremendous improvement. And this is mostly due to recognition of treatment of risk factors such as hypertension, hyperlipidemia, and diabetes, then followed by recognition of atrial fibrillation between 2003 and 2009, and the initiatives of Get With the Guidelines, another good systems of care initiative that started showing increased use of anticoagulation for atrial fibrillation, and that increased from 20% to 69% in the early 2000s. Finally, TPA became available in the mid-90s, and now we're working with a change in stroke systems of care. And from the stroke side, we're kind of encountering a new era in stroke treatment that further expands our capability to provide acute treatment with some advanced imaging. And this is something that we're working on getting into a lot of hospitals, and something that Dr. Albers, the head of our stroke center, has worked a lot with in terms of advanced perfusion imaging. So we all can agree that stroke is a major public health burden. In the 80s and 90s, as we said, cerebrovascular disease was listed as third caused by the CDC, but improvements in treatment and prevention have demonstrated substantial impact on mortality, bringing it to then the fifth cause of morbidity and mortality. The risk of stroke varies by age, gender, and ethnic group. And I think it's important to think of all of these things really in the same regard. Men are more likely to have stroke than women throughout a large portion of the lifespan, but women generally outlive men. And over the age of 75 to 80, women are then more likely to have a stroke than men, and it's poorly recognized and poorly treated. And as we've heard, for cardiovascular disease is also poorly studied. Among the ethnic groups, American Indian, Alaskan Natives, African Americans, those have the highest prevalence of stroke, and many women in these ethnic groups are also having consequences of being undertreated and having poor access to care. So this is a slide showing stroke due to ischemia. It's about 68% of strokes globally, more around 80% in the United States. And we also see the heavy burden here in the southern states in the United States. And this is attributable largely to behavioral and lifestyle factors, socioeconomic status, as well as access to care. We've talked a lot about some creative ways that we can improve people's access to care. Telemedicine is one of them, and something that many centers, including ours, are working on. These are the stroke hospitalization rates between 2015 and 2017 that were posted by the CDC. This is a similar map demonstrating the hospitalization of patients over the age of 65 enrolled in Medicare. It's a little bit more recent and shows the same predilection for the southern states. The younger population's excluded, but they make up a very small minority of strokes. I thought this was also really interesting to show, again, another societal burden on women. It's a chart from the US Census Bureau reflecting the percentage of households led by a single mother in the year 2018, showing the same inequitable burden on women in the southern states that can affect health, socioeconomic status, as well as access to care. So in bridging the disparities in healthcare, the first step really is recognition. So this is one of the flyers we give to all of our patients at the Stroke Center. And next, we want to ensure access to care for adequate workup and diagnosis, then ultimately prevention. And I think it's worthwhile to briefly review the stroke subtype, since each has implications for different risk factors and can change in terms of the risk throughout the lifespan of a woman. So mechanisms and pathophysiology really best considered in the context of stroke-specific subtypes. And there are really two flavors of stroke, ischemic being 80% and then 20% being hemorrhagic. And then of those ischemic, there are 5 subcategories that we can focus on today when thinking about women's health initiatives. I'll really focus on the first 3 as the risk varies for each by gender, age, and risk factors: cardioembolic, lacunar strokes and small vessel disease, and then large artery atherosclerosis and atheroembolic. We will be talking a lot about stroke in pregnancy, which involves a lot of the stroke of other etiology. And unfortunately, many times stroke etiology remains undiagnosed, and a substantial portion, some reports up to 30 and 40%, remain as cryptogenic or undetermined cause in our literature. So just as a review, atherosclerosis, we know increases in women once the protective effect of estrogen is no longer present in menopause. And as a reminder, this can happen not just in the cervical arteries and in the cardiac arteries, but this can also be true intracranially in the blood vessels in the head. So it's important for us to recognize this, and I think screen for this in patients that have other risk factors and have had strokes in some of these territories. We spent a lot of time already talking about cardiovascular disease in women, but I'll just remind us that there's several cardiac conditions that are potential sources of embolism. And atrial fibrillation in particular is a very common finding in women, especially over 80, and it's very much under-recognized and under-treated women, and a huge risk factor for stroke. And importantly, it's such a treatable entity. So it's something that I think we could do a better job on recognizing and treating, especially in our older female patient population. We know that recent myocardial infarction can facilitate the formation of cardiac thrombus due to endothelial damage, and strokes due to MI are most likely to occur within 5 days. So we should be really aggressively treating these patients. And we also heard from Dr. Bairey Merz that many of these patients, stroke similarly, are not being treated immediately with their statins, with their antiplatelets when this occurs. And that also subsequently increases the risk of stroke. And when we talk about the increase in morbidity and mortality really in that first year, it's understandable how the snowball effect happens when the core cause, if it's cardiac in nature, is undertreated and under-recognized. Then a person starts having strokes, incurring disability, and ultimately can lead to death in that first year. So there are several well-described risk factors for ischemic stroke, and these are of course present in both women and men, and notable to varying degrees along the lifespan of a woman. We also talked about these certainly present in cardiovascular disease, and it's so much so that we really think of cardiovascular and cerebrovascular disease as a continuum in our clinic. So the underlying conditions increasing stroke risk that we're all aware of are hypertension, dyslipidemia, diabetes, heart disease. There's family and genetic risk factors, of course. And then additional behaviors that can affect risk of ischemic stroke are alcohol use, tobacco, physical inactivity, unhealthy diet, and many others. And now we get to the gender differences in stroke and how these present differently, how we recognize them differently. And reproductive factors strongly affect stroke risk and incidence in women across the lifespan. So we know about hormonal influences, pregnancy is such a high risk time in a woman's life, arguably the highest risk time in a young woman's life. And hormonal contraception, as well as replacement therapy after menopause, affects our stroke and cardiovascular risk. Presenting symptoms of stroke vary between women and men, and this can really affect the timely recognition, diagnosis, and treatment. And our mantra in stroke, as it is in cardiology, is time is brain. And while we have other options for patients who don't present right away, they're less so. And we do have the best opportunities for reducing disability if we're able to treat patients early and effectively. And we'll talk about how the presentation differs between women and men, just as it does with cardiovascular disease, and how it can lead to under diagnosis and under treatment of female patients. Stroke outcomes are influenced by age, pre-stroke functional status, and comorbidities. And these may be affected in women, especially as they live alone and they become more elderly at 80 plus in terms of the severity of their stroke, their functional status, and if they're living alone. So I'll just briefly share a slide on pediatric stroke, infant to 18 years. This won't be the focus because the mechanisms are so different, but the incidence of stroke in infants and children is anywhere from 0.6 to about 8 per 100,000 children per year. Also, this has a similar prevalence in a lot of these underserved populations we saw in those early slides from the CDC in terms of ethnic disparities. American Indian, Alaskan Natives, and African Americans have the highest prevalence of stroke. And it's for some reason most common in boys than girls, and that's not well known yet. Risk factors and causes of stroke more include congenital and acquired heart problems in the younger population, as opposed to some of the more classic cardiovascular risk factors we'll be focusing on: hematologic condition, vasculopathies, dissections, trauma, metabolic disorders, as well as drug ingestions. Another crossover with cardiovascular disease that's important for us to recognize in these younger patients is, especially in the setting of cryptogenic or undetermined stroke source, is patent foramen ovale. It becomes a really important contributor in these patients. So PFO has been reported to be present in anywhere from 10 to 35% of all people. We generally quote an average of 20%. And before 2017, there was really poor evidence of how to treat or manage these patients with PFOs. However, there are 3 trials that came out that year: RESPECT, REDUCE, and the CLOSE trials, that showed a reduced risk of subsequent ischemic stroke in patients assigned to PFO closure combined with antiplatelet therapy than among those who are on antiplatelet therapy alone. PFO closure, however, does have a known variable risk of atrial fibrillation, and that is something to be considered. But we do know now that in patients 16 to 60 years old with a recent cryptogenic stroke attributed to PFO, and we haven't found another cause of it, and they have associated high-risk features, perhaps an atrial septal aneurysm, large intraatrial shunt, we were better able to define the risk features of PFO in these more recent studies, that they're more likely to benefit with a closure plus long-term antiplatelet therapy than with antiplatelet therapy alone. So it's an important screening tool in regards to cardiac etiology for our younger patients. So epidemiology, sex and age influences stroke diagnoses in the United States. We know between the 20 to 9-year time period, there's a similar prevalence of stroke between men and women. Then in that 60 to 79-year period, there's a higher prevalence of stroke among men. And then by the time women is 80 years and older, there's a higher prevalence of stroke among women. We know that race and ethnicity are significant predictors of stroke incidence and outcomes. And this has a lot to do with socioeconomic status that's measured in most of these studies in terms of insurance and education. And that also in turn affects access to care and affordability of care and ability to afford treatments, medications, et cetera. And importantly, we've talked about how presentation can differ so greatly between men and women, even with cardiovascular disease and atypical presentations and symptoms that a woman may present with an acute coronary syndrome. This is also true for stroke. The presenting signs and symptoms can vary pretty significantly between women and men, and this can affect timely recognition. And with stroke, we just have hours to give thrombolysis, TPA. We can, in some cases, do endovascular therapy to the 24-hour window, but that's only if a patient has advanced imaging that's favorable. So looking at this just brief chart that I have on this slide, women present with some more non-specific symptoms. They may be more likely to present with generalized weakness, changes in mental status like disorientation, memory deficits, and confusion, fatigue, headache, and even pain, while men present with a few of the more classic stroke signs: paresthesia, ataxia, double vision, nystagmus, slurred speech. But of course, we still look for the most common classic signs: unilateral findings of weakness, numbness, tingling, posterior circulation, signs of vertigo, double vision, etc. But men don't have this other presentation that women do. And you can see how these symptoms would be more likely to be attributed to some systemic process or fatigue or urinary tract infection, and we would miss the opportunity potentially to treat an early stroke. Other things that affect a woman's presentation include the fact that she's often older, may live alone, and have increased comorbidities. And that's, what we refer to as the age effect in all of these studies. And then in terms of disease, women are more likely than men to have a cardioembolic stroke and more severe disease, but they're unfortunately less likely to be treated with anticoagulation versus men. And we've seen this in the cardiovascular data that was just presented, where we saw in several studies, they're less likely to be treated with statins and antiplatelets after a coronary syndrome. And it's a real missed opportunity in terms of preventing disability and death in these patients. The age at menarche is actually important. And this is a very interesting finding, I think, and highlights some of the disparities in our socioeconomic status in this underserved population. So there's actually a U-shaped curve we see at the bottom of this slide between age at onset and the incidence of stroke. There's a large UK study that looked at this in women between 60 and 64, and an onset of menarche at 10 years or younger increases future risk of stroke by about 25%, and an onset at 17 years and older also increases a relative lifetime risk. So there's this golden time period between 10 and 17 where you'll have a lower risk due to the expected lifetime estrogen exposure. This actually had the strongest trend in coronary heart disease, interestingly, but also had a similar effect in stroke. Hypertensive disease also had a similar trend in this study, showing this U-shaped curve in age at menarche. So some of the associations that were considered include lower socioeconomic status is associated with earlier onset of menarche. Why this may be is still a large area of study. Childhood obesity may be contributory, also having to do with lower socioeconomic status. Increased and longer duration of exposure to estradiol and earlier onset of puberty is all thought to affect the hormonal axis and estrogen exposure long-term, which will have implications for both cardiovascular disease, including hypertension, and cerebrovascular disease as well. So contraception and hormone replacement therapy. I'll talk a little bit more about hormone replacement therapy, but the principle regarding estrogen exposure is very similar. There's up to 2 times increased risk of stroke in women taking estrogen-containing oral contraceptives. And there's a dose-dependent relationship of estrogen, 1.7 to 2 times greater risk versus non-users. And we always tell our patients that any oral contraceptive agent, specifically estrogen-containing oral contraceptive agent, should be avoided in women with a history of any stroke, including pregnancy. And the reason is physiologic levels of estrogen can decrease activity of pro-inflammatory pathways that offer that protective cardiovascular and cerebrovascular effect in women into the older age years, and it can decrease clot formation, endothelial damage. However, the estrogen that is supplementary in these medications may be too high and has a deleterious effect in these situations. And when we also think about contraception and its risk of stroke, we also have to consider this in the context of younger women who may also smoke and have migraines, specifically migraines with aura, and that's our trifecta of increased risk of stroke: oral contraceptives, smoking, and migraine. And I'll talk a little bit about migraine in some future slides. So alternatively, there's no evidence of increased risk of stroke or MI in women using progestin-only containing contraceptives. This includes oral contraceptives, injectables, and implantable intrauterine devices. There was some data in smaller studies that some of the patches may increase risk of venous thromboembolism, but not arterial clots. But this hasn't been repeated in many studies, but is something that we ask about when screening patients with cryptogenic stroke, if they have any exposure to these, especially if they may be younger, have a PFO, and had symptoms consistent with a venous thromboembolism. So pregnancy, I'm going to spend a few minutes on pregnancy because it's such a high risk time in a woman's life, and that's probably the highest risk of stroke that a woman will experience during her life in most situations. The risk of stroke increases 3 times during pregnancy and the postpartum period, about 30 per 100,000. Ischemic, hemorrhagic, and cerebral venous sinus thromboses all increase. Risk factors are age greater than 35 at pregnancy, eclampsia, preeclampsia, smoking, and C-section. C-section may be a bit of a confounder because most obstetricians are likely to recommend C-sections in higher risk women, especially those of older age. They do call it geriatric pregnancy at ages 35 and older, and also in patients who have hemodynamic instability with eclampsia or preeclampsia will be treated with C-section usually. There are hemodynamic and vascular changes that occur throughout this time, including fluid retention, venous stasis, decreased vascular resistance, increased cardiac output, and heart rate. There's also intrinsic collagen and elastin changes that occur in the blood vessels that affect compliance, endothelial dysfunction, potentially increasing risk of clotting, as well as vessel wall permeability. And then there's interesting physical changes with structural compression, potentially, of the vessels in the abdomen and pelvis. So we've known from older studies for some time that there's an increased rate of stroke that increases hypertension as well as chronic heart disease. And this increases in the postpartum period. And we've also seen a temporal increase between the mid-90s and then the mid-2000s in some older data. And somewhat hot off the press, there was just an article published last month in Neurology about stroke and pregnancy in the puerperium. And just in terms of the terminology, puerperium generally refers to the first 6 weeks after delivery, but really more generally refers to just the time period after delivery. And we can consider the puerperium really as long as we'd like. It generally refers to 6 weeks, but we may make some arguments that there's an increased risk through 12 and potentially even 16 weeks after delivery in terms of thromboses. So this study was a Finnish study just published last month, and it looked at the rate of pregnancy-associated stroke over 3 decades, 80s to the mid 2016, and retrospective population-based cohort with a nested case control was the study model. And it looked at pregnancy-associated stroke, which was defined as ischemic, hemorrhagic, subarachnoid hemorrhage, and cerebral venous sinus thrombosis during pregnancy or the puerperium, which they defined really looking through several weeks. I believe they followed them to 18 or 22 weeks to see what events occurred at which point. They calculated the pregnancy-associated stroke rate per 5-year age groups and per number of deliveries. And we found, again, evidence that this is associated with age, smoking after 12 weeks gestation, migraine, and hypertensive disorders during pregnancy. So here's one of the figures that was shown in this new article, that the significance for trend has really increased. And we see the highest line here is most significant for ischemic stroke. That's gone up through the decades since the 80s to the mid-20-teens. And then next in line was cerebral venous sinus thrombosis. Next was intracranial hemorrhage, and then finally subarachnoid hemorrhage. And from a stroke standpoint, those may be more often associated with the hypertensive etiologies in stroke. And here's the distribution of stroke subtypes across pregnancy trimesters and postpartum period. And we can really see there's an increase in the third trimester, and specifically in the postpartum, the 0 to 6 weeks is the highest risk time, with still some increased risk into that 7 to 12 week range. This study, unlike some of the older studies from the mid 90s and then the mid 2010s, did show some similar risks of these strokes in the second trimester. And traditionally, we think of them as occurring more in the third trimester and then the postpartum anywhere from 6 to 12 weeks. So the data for the increases in pregnancy-associated stroke showed that there was an increase from 11.1 to 25.2 per 100,000 deliveries between 1987 and 2016. The incidence increased by age, whereby women in the 20 to 24 age group, that was the youngest age group they looked at, had a rate of 9.8 per 100,000 births, and it was 29.9 in women over 40. There's a 5-fold higher risk in the early postpartum period, and the most important risk factors we saw were smoking, migraine, and hypertensive disorders. And we're always asked, what about migraines causes increased risk of stroke? And the long story short is we don't really know, but there is an increased tendency to form blood clots due to temporarily narrowed vessels in migraines. And the thought is that it might be a vasospastic process. We can also sometimes see evidence of chronic small vessel disease in patients that are longtime migraine sufferers. So we think that that's the cause. And for this reason, we recommend patients not have any vasoactive type of medications for migraine if they've had a stroke or cardiovascular event, because that could be vasoactive and cause further spasm. So the conclusions to this study were that pregnancy-associated stroke is increasing, and we need careful pregnancy surveillance and risk factor management, particularly in older expectant mothers. And we need this also to extend well into the puerperium, 6, and I usually recommend 12 weeks for most patients, and I'll review some of that older data too. Pregnancy is also an interesting time because it has an effect truly on every system in the body. So it affects the coagulation cascade, where you have a hypercoagulable state with the greatest risk during the late third trimester in the puerperium, potentially up to 16 weeks, which we'll look at some of that data. Acute blood loss can be at fault, physiologic protein S deficiency, iron deficiency, anemia, and dehydration. There's also increases in procoagulant factors, in turn decrease in coagulation inhibitors, increases in thrombin generation and fibrinolysis, and platelet consumption. And this is all a process that really prepares the woman for delivery and for the bleeding that occurs with the delivery, but it can be pathologic and cause a lot of clotting problems. This is just a review of the hypercoagulable state in women. And some of the physical changes are actually quite interesting. Because of the increased mass effect in the abdomen, you can have compression of the IVC and iliac vessels. I think this is a really interesting finding. It's classically called May-Thurner syndrome, can also be called iliac vessel compression syndrome, but it is caused when the left iliac vein is compressed by the right iliac artery, and that can increase risk of DVT in the left extremity. And we think about this often as an entity for potential DVT occurring in the iliac veins in pregnant women, but I think it's also something for us to consider in our minds as well for patients with lots of cardiovascular risk factors who may also have a lot of abdominal obesity, and potentially worth screening for with an MRA of the pelvis, CTA of the pelvis, looking at those vessels. If we have a patient with a lot of abdominal mass effect and who has a cryptogenic stroke and may be young, in turn, we would also screen for PFO if we thought that that was potentially a cause, especially if that's already been identified in these patients. There can be compression really of any of the vessels, the aorta, the uterine arteries and veins, and there can also be decreased venous compliance because of the collagen tissue effects of pregnancy that can really form a perfect storm for allowing clot formation and decreasing nice flow of blood throughout all of these vessels. The hemodynamic changes are many: sodium and water retention. These can also increase hypertension along with an increase in renin activity. There's increased levels of prostacyclin that can affect vascular resistance and affect blood pressures. Venous stasis, RBC mass is affected, hemodilutional anemia due to increased plasma volume. And then there can also be increased stress on the heart with increase in cardiac output, stroke volume, and heart rate, especially during the hyperdynamic state later in pregnancy when the blood volume is expanded by about 50%. We talked briefly about the vascular and connective tissue changes. Reduced collagen and elastin content and arterial wall can lead to increased stiffness, endothelial dysfunction, vasogenic edema, and compliance issues can be a part of it. Some of the older data that we looked at, one of the more landmark articles when we look at pregnancy-related stroke and thrombotic events was the article in the New England Journal of Medicine in 2014 by Kamel. And here they looked at about 1.7 million Californian women hospitalizations and their deliveries between January 2005 and June 2010. They defined thrombotic events as stroke, MI, or venous thromboembolism. The risk factors were being older, white, or African American versus Hispanic or Asian, less likely. The other risk factor was no private insurance. So again, we're really seeing influences in public health and societal factors and socioeconomic status directly influencing health and health outcomes. The other risk factors that we see presenting themselves time and again were advanced age, hypertensive disorders of pregnancy, the eclampsia spectrum, a primary hypercoagulable state, smoking, and then cesarean delivery, which I mentioned could just be an effect of having a high-risk pregnancy. This is the chart that we most frequently reference when I'm talking with patients or talking with other providers about the period for which we want to monitor a patient closely or which we want to continue some type of antithrombotic or anticoagulant if they're a high-risk patient. So you can see here that at 13 to 15 weeks, the odds ratio of any thrombosis is 2, and it doesn't quite go back to 1 until we're at about the 20-week range. And this is the data here stratified by weeks: 0 to 6, 7 to 12, 13 to 18, and then 19 to 24. And we can see here that the absolute risk difference is pretty substantial. And there's a significant odds, especially in the 0 to 6 weeks, but really does extend through week 12. And here I'll highlight, you see that venous thromboembolism drives the increased odds ratio in the later weeks beyond 6 into the 13 to 18 weeks actually. And this can still be problematic, especially if our patient has a PFO and can also increase risk of stroke. So it's something that you may want to consider DVT prophylaxis for, especially if they have an underlying hypercoagulable disorder. You may consider full anticoagulation during this time. So the take home really for thrombotic events during pregnancy is that there is a clear increase in risk for at least 12 weeks, though small after 6 weeks, but something that we can screen for and I think selectively treat in patients that require this therapy. So during pregnancy, there appears to be a much smaller increased risk of hemorrhagic stroke and no real clear increased risk of ischemic stroke, but that's during pregnancy in that first column. But there is evidence for increased risk during the postpartum period that's quite substantial. There's a significant increase in the relative risk of both ischemic, 8.7 risk ratio, and hemorrhagic is really high, 28.5 for at least 6 weeks after delivery. And a lot of that, again, is related to those hypertensive spectrum of pregnancy-related disorders. Just wanted to include for completeness the rare causes of stroke in pregnancy, such as choriocarcinoma, amniotic fluid embolism, air embolism, and Sheehan syndrome. There are many others, but just important things for us to keep in the back of our mind when treating these patients, since oftentimes their stroke will be a first presentation of something that was accentuated during pregnancy and the postpartum period. So pregnancy complications and sequelae, we know that this is increasing along with hypertension and cardiovascular disease. And there's been an 83% increase in stroke between the 90s and the mid 2000s, and most of it's in the postpartum period, as we saw from some of those tables. The hypertensive disorders of pregnancy are associated with all types of stroke. And we really think of the vasculopathies, RCVS, reversible cerebral vasoconstriction syndrome, and posterior reversible encephalopathy syndrome. We think of those as a continuum, really, of the eclampsia, preeclampsia spectrum. So really important to treat these underlying cardiovascular risk factors and diseases in patients very carefully during this time. We know there's an increased risk of premature birth, maternal morbidity, and mortality. It increases up to almost 30% during this time. And there's also an increase in future risk of all of these entities that put us at risk for future stroke, cardiovascular disease, heart failure, and hypertension once they're incurred during pregnancy. So it's a really important opportunity for us to screen and bring these patients into the healthcare system after delivery and maintain prevention for them really throughout the rest of their lifespan. So finally, we've seen this theme in so many of the trials that were already presented. There's such a risk of withholding therapies at this time. TPA and endovascular therapy, according to the guidelines, may be considered in pregnancy. And I added my own parentheses as should. We should always be considering it. We should always be having these conversations. And generally speaking, we want to treat acute stroke in patients because it has a low morbidity, low mortality, prevents morbidity, especially if she's going to be caring for a family or being responsible for more children. Secondary prevention, we want to make sure we use this as an opportunity for comprehensive cardiovascular workup, blood test imaging, any additional consultations, identifying and treating underlying risk factors to set a woman up for a healthy life through subsequent decades, diagnosing and treating underlying disease, and really providing antithrombotic therapy where appropriate if this may be her only contact with the medical system. So for pregnancy-associated stroke, the conclusion really is that they're uncommon complications of pregnancy, but they happen often enough, and it has a very substantial societal impact. Most ischemic strokes, cardiovascular disease, as well as cerebral venous sinus thrombosis associated with preeclampsia, eclampsia, intracerebral hemorrhage occur during the early postpartum period, and this is the time of greatest risk. There can be a hypercoagulable state that we need to recognize in the late postpartum, really through 6 to 12 weeks after delivery. The preeclampsia, eclampsia syndromes are major contributors to underlying stroke, as well as a future of cardiovascular and cerebrovascular disease. Most patients have identifiable predisposing conditions, so we need to make sure we're screening these patients appropriately beforehand in both the primary care and OB settings. And importantly, pregnant women should receive full evaluations with precautions for unique risks and the full range of available therapies to reduce risk of long-term disability. So the final couple of slides are just going to be on menopause and hormone replacement therapy, since this is a frequent discussion on our clinics. Younger age at menopause is associated with increased ischemic stroke risk. The average age is 51. Onset before 40 can carry an increased risk of coronary heart disease and all cardiovascular disease, as well as ischemic stroke, and that's the reproductive lifespan effect. Estrogen deficiency decreases regulation of the inflammatory response. And we talked about this a little bit with the oral contraceptive therapy, where physiologic levels of estrogen can decrease activity of the pro-inflammatory pathways, but the replacement therapy concentrations are much higher, and you can lose that protective effect and also have a deleterious effect. Estrogen itself has a protective effect on blood vessels that is lost after menopause. And one of the things that I find very interesting is we can really pay attention to what women are telling us regarding their menopausal symptoms and use that to help us stratify risk of stroke and cardiovascular disease. So women experiencing these common sounding menopause symptoms, such as hot flashes and night sweats, I when we read, they're listed as high as 82%. And these are actually associated with cardiovascular disease, including hypertension, hyperlipidemia, autonomic system affecting sleep, anxiety, and mood. And these are really our high risk patients who may be at increased risk of stroke and heart disease. Hormone replacement therapy for vasomotor symptoms may also increase risk for thromboembolism. And there was a huge shift, as everyone remembers, from treating everybody with hormone replacement therapy in the 80s to now really avoiding it if possible. And we do have data that shows hormone replacement therapy initiated more than 10 years after menopause increases risk of thromboembolic disease. But if it's initiated less than 10 years, has much less risk to potentially no risk, according to certain studies. It should be avoided completely if there's any history of cardiovascular and cerebrovascular events, or if the patient is deemed to be very high risk by some of our additional stroke and cardiovascular calculators. Transdermal creams are much safer than oral, and those are underused and something that we should remember when treating these patients. So this is the flowchart for identifying women appropriate for postmenopausal hormone therapy. And you can see by the time they come to stroke clinic, and likely by the time they're seeing Dr. Bairey Merz in clinic, they're going to be in that no category, unfortunately. So if you have significant symptoms of menopause, such as moderate to severe hot flashes or night sweats, the recommendation will be avoid hormone replacement therapy. And then if you've had any history of stroke, CHD, TIAs, then it's also going to be a recommendation to avoid hormone replacement therapy. So this is something that we should make sure we work really, really closely with our primary care prevention providers on as we treat these patients in the future. And so finally, treatment and prevention of stroke. We know that presenting symptoms of stroke can vary between women and men, and it can affect recognition, diagnosis, and treatment. We know that more strokes occur in women older than 80, and that much like a lot of the cardiovascular trials, they're excluded from trials and are also often excluded from receiving IV thrombolysis based on age. Age criteria more so than men, despite we know there being a similar benefit in this age group. Women obtain the same benefit also from endovascular therapy, but for whatever reason, they're not included and not offered this therapy as often. And revascularization in terms of doing intra-arterial therapy is more important than age and outcome after thrombectomy. So that's important to think about. Women are underrepresented in stroke trials, about 40% of the study population, and this can also lead to withholding beneficial therapies when it feels like there's not enough evidence to treat a lot of these patients. So the final message is recognition of disparities, including signs and symptoms of stroke, risk factors, and hormonal effects across the lifespan, and additional inclusion in research should improve outcomes for stroke in women. We do have a special women's heart health clinic here at Stanford, and we're trying to work with them more closely to improve cardiovascular and cerebrovascular health in patients and also improve screening. And I'm also wanting to start a pregnancy registry here, but the patients can be few. So it's something that we'll be working on in the future, hopefully. So thanks so much for allowing me to share about this important topic today. I'm happy to answer any questions or discussions from the panel.
Thanks so much, Dr. Mijalski. That was great. And I really appreciate you highlighting pregnancy as both experienced geriatric pregnancies ourselves. I think it's helpful to know that that risk factor is there. And I think a huge takeaway from both the presentations today is really how women's symptoms are under-recognized by the healthcare system, need to be taken seriously, and particularly in the peripartum period or the puerperim period, so the 3 months after pregnancy, to remember that the risk is greater and you need to consider as a provider things like stroke risk where you may not normally see the classic risk factors. So thanks for sharing that. Let's open it up to questions for either speaker. And I'll just take a look here. Oh, Dr. Rana, is that your hand?
Yes, thank you for having me. This is for Dr. Merz. So just first of all, a lot of gratitude Dr. Merz, for speaking to us here today. Full disclosure, I was a fellow at Cedars-Sinai 10 years ago.
Good to see you, Jamal.
Yes, I'm very humbled to, currently I'm sort of supporting ACC California, so I'm very humbled to have that. Yes. So I think this is something, a question and comment that you actually pointed out is towards that, how when we talk about cancer, there's so much awareness in our national sort of discussion. There was a study came out in Circulation where they talked about women's awareness about women's heart disease in 2009, and then again in 2019. A decade later, there was even less awareness about severity of heart disease and stroke among women. So what kind of dialogue or discourse at national level can we have? Almost wish that we could record all those quotes and statistics you spoke and make big headlines and get some more, I don't know, so any comments on that?
Yeah, I mean, one of the policy issues that we're actually working on is there are metrics that, you know, help you understand how to dispense research dollars according to morbidity, mortality, and disability burden. And it's a little bit like having quotas, right, for gender and race, ethnicity. So there's always pushback about that, you know, Francis Collins, our NIH director, will say, well, we have to go where the science goes. But I think you know, as I get older, I'm kind of believing more in policy and having metrics and having things that you can measure. And, you know, the retort that I'll have the next time he says that is, well, come on, we had a pandemic and we told these companies, you have 6 months to come up with a vaccine and here's your tools, here's the money, do it. You know, it's like those engineers at Apollo 13 or whatever it was. They figured it out. They got them back. So I do think that I think that'll be things that we, and this group is a good policy group that can advocate in our progressive state that, you know, time's up. It's enough for this disparity.
Can I suggest that perhaps you draft a letter and we try to get signatories across the Right Care Initiative to do this? I was working it within the state government to say, let's go with the law of large numbers. What's killing people? Let's put our resources there.
Yeah.
I like that time's up. It's urgent. We cannot, what are we waiting for? So thank you so much again.
Well, but I have one other thing that I would be curious in what you and others thought about it, because we've also done some work. We've done some interviews and focus groups working with UCLA linguists and English professors. And they do these like analyses of text, because when a woman under the age of 50 is diagnosed with breast cancer, it's a very different reaction and a very different friends, family, and societal reaction than when a young woman is diagnosed with a heart attack or a stroke. This is very comforting and let me help. And what can I do? And let's pick out a wig and you're going to be okay. And this is, yeah, you should have lost some weight. Or really, you smoked in college? You know, it's really a blame the victim kind of issue. And some of it, you know, maybe is justifiable. We really do know the risk factors for cardiovascular disease, although in young women, as we heard in the stroke, it's a lot more complicated. It's not just cholesterol. And we really have very few risk factors for something like breast cancer. So it is more of a random, you know, when people think it's random, they're more likely to circle the wagons. So what do people think we could do about that? Because that's very cultural.
Yeah. Very thought-provoking. Yeah, thank you. Yes.
Yeah.
I think we can start at the schools. We can start teaching our children about blood pressure and cholesterol, have them write papers on it, etc. And I do believe that Bill Baumer is very well connected at the Capitol. And we might actually have a bit of an opening right now because the state of California has such a big surplus. So let's
We
think
could
about
do a campaign. Mhm.
And I think
Yeah.
as providers also, we frame it for some of our other patients as you're a survivor, right? You're a breast cancer survivor, you're a stroke survivor, you're a heart attack survivor, and building the empathy in each of our interactions with our patients, I think really helps. We do that a lot in stroke, and I try not to look at who's a woman or male or female, age. Everyone is a survivor in our clinics, and we connect them with the resources. So we need to do that as providers as well.
Yeah, I agree.
Yeah, and I think making sure everybody has excellent access to primary care, and hopefully the one good thing that comes out of COVID will be all of our comfort with telehealth and really extending into patients' home for screening and getting people a little bit better connected, even if it's just by their phone.
Mhm. Mhm.
Looking at some of the other comments in the chat so we get to them. Robin Flint, sorry, it's cutting off the last name, McBride, thank you, asked, could you speak to why the HEDIS standards for statin therapy for members with cardiovascular disease only looks at women ages 40 to 75, but for men ages 21 to 75? Given the data you presented, Dr. Bairey Merz, it sounds like the guidelines really shouldn't be different for them.
The guidelines are supposed to anchor on the participants that were enrolled in trials. And one of the younger studies was AFCAPS, because they enrolled in Veterans Administration and active duty military hospitals or military. Yeah. And I actually didn't know that about HEDA, and I would be surprised, but you know what? I will look it up, AFCAPS. I'd be very surprised if it went down to 21. And so I don't know that. That's, yeah, it's not good.
Thank you. And Susan Hansen asks, can you talk about the sex differences in CAC scores and the ramifications of that?
Yeah, this is a good question. So the CAC scores, the coronary artery calcium, so these are the fast CTs, it's less than 1 millisievert of radiation. Yeah, it is a millisievert of radiation. And so this whole idea that we would consider this as a population screening test is, would be challenging because it ranges anywhere from $100 to $300. It's out of pocket. Health insurance doesn't pay for it because, again, it's considered screening, and it does radiate lungs and breasts. They've gotten the radiation down, so it's not crazy to think that there could be a randomized controlled trial, as I suggested earlier, in at-risk folks to really determine who might best benefit from a statin. But that aside, sex differences. So it works equally well, with the exception of young women, again, under the age of 50, if you needed a threshold. They are less likely to be calcified, and maybe that's an estrogen thing. We don't know why it is. And so they won't have a positive calcium score, even though they do have plaque. And uncalcified plaque is considered less stable plaque. And so it's a screening test that is 95% accurate, but that 5% will often be a young woman, and they get missed. So they are falsely reassured when it's not calcified.
Thank you for sharing that. That's an important distinction. We're big proponents of CAC here at Right Care. And
it's our best risk stratifier. It is. The hazard ratio is 10. Where do you get a hazard ratio for a preventive screening of 10?
Yeah.
It's huge.
Yeah, and then when it's about mammography, nobody talks about that's very accepted thing, 40, 45 yearly radiation. Yeah. So I think that's where we're coming from. So
yeah. And women are happy to radiate their breast, right? Because they fear breast cancer. And whenever insurance company tries to limit it because there's no good data for under the age of 50 or 55, I can't remember, the women all scream, they're denying me care. Yeah.
Is there a test for the non-calcified plaque that could be done earlier for women that you recommend, Dr. Merz or Dr. Mijalski?
I'll go first. My colleague, Dr. Jana Way, has an NIH grant with cardiac MRI trying to do that, and it's turning out to be pretty challenging.
I couldn't hear the last part of what you said.
Cardiac MRI. but we're 4 years into the grant and it's not looking very good.
So not yet.
Not yet.
And I would say the same thing for cervical or cerebrovascular vessel disease. MRI would be the best way to determine those soft, unstable plaques from those longstanding calcified plaques. CTA obviously is cheaper, quicker, but it has more radiation. And I just don't know that it's feasible to use MR as a screening tool for that.
Yeah, I think the best detection of vulnerable plaque right now has been shown with both IVUS, intravascular ultrasound, and infrared spectroscopy, but both of those require a catheterization, so they're hardly preventive screening type of modalities. But those two ways do identify vulnerable plaque that is at higher risk for rupture, and it's based on the lipid content of those plaques.
But I think above all, what both of you have shared today is that there's so much low-hanging fruit of just doing the right therapies for those that are already identified at risk, that it's just not being delivered, you know, independent of CAC screening to find that other intermediate risk group. And so I think that that's where health systems really need to be mindful and use the data-driven algorithmic checkboxes to hold ourselves accountable so we don't let disparities take over.
Yeah, for example, the Dr. Baumer's slide about the yellow bars, sex stratify those bars.
Mm-hmm.
And
do we do that, Hattie? Can we do that?
Sure. Yes.
And then, you know, set your goals.
Distracted by a chat from Steve Sidney about breast calcification. Could you re-express the question and I'll try and answer it? What is it that you're
can we sex stratify the county level data?
The yellow bars. We have yellow bars across.
We don't have that data, but I think it's a good suggestion. I'd love more data. I'd love more involvement from state and county public health on cardiovascular disease. They are very thinly staffed. And honestly, right now, getting good data out of the state is a problem. So even having the data that we have is better than a lot of states.
Oh, yeah.
And I see another question in the chat box from earlier. The new glycemic drugs, SGLT2 inhibitors and GLP-1 receptor agonists demonstrate meaningful benefit on the 3-point MACE, the cardiovascular outcomes in clinical trials. Is there a unique impact for female cardiovascular syndromes with these compounds?
They are sex stratifying the data. It's kind of not okay anymore not to do that. I haven't seen any glaring differences. The SGLT inhibitors do spill more glucose in the urine, and women have more vaginal introitus to, you know, develop yeast infections and UTIs, where men's reproductive is a little more protected against bacteria and yeast. So I believe I've seen that. That's just a side effect, and kind of a pesky side effect, given the fact that you live longer. And but what they are doing, because the SGLT2 inhibitors, I think, have the best data so far, and they really appear to be very beneficial in heart failure with reduced ejection fraction, which is a male and female disease. They are now starting, and clinical trials are just coming out for heart failure with preserved ejection fraction, and that'll be interesting because that would be more female dominated if it turns out to be, and it would be our first effective therapy if that turns out to be true. The semaglutides, et cetera, those are looking at, for MACE, like they're more of an anti-atherosclerotic mechanism, and there's, I would say, overall less data about that specifically compared to the heart failure with the SGLT2s. But it's pretty interesting, and you probably all saw that JAMA paper within the last year, that even in the absence of diabetes, it's quite safe and effective for weight management. And, you know, we talked about, you know, a lot of these CVD curves that are stagnating are probably because of obesity-associated diabetes, hypertension, dyslipidemia. So the idea that we actually would have something that would help with our obesity epidemic is fascinating, and we hope that we can do that.
I see that it's 6 o'clock and time to wrap up. Any final questions or comments from our panel?
I had two quick questions, one for Noel, which was, you showed interestingly about a 50% awareness in women of the fact that cardiovascular disease and stroke are killers for them. Who would be the appropriate messenger to reach out to those people? You're preaching to the choir right here, but those people who need to hear about it are not here and may not be seeing health providers. And Ron reached out to barbershops and groups like that. Is there a different messenger we need to identify that actually can take the message to those people?
I completely agree. And, for a decade, when it was clear in the 80s of this problem, we had, Red Book and Women's Day and the traditional women's throwaways, in the grocery store, and they were on it. But, I think people don't read that anymore. It's all about social media. One of the things that we did try early on also, and we're looking for suggestions, is celebrities.
Yes.
Yeah.
TikTok celebrities. Yes.
And just like celebrities, back in the day with breast cancer, Nancy Reagan stood up and said, "I'm a breast cancer survivor." And all of a sudden people could talk about it because she and Betty Ford. So, but it remains kind of this shameful thing. And somehow it's your fault that you got it. And a lot of people don't want to talk about it. Rosie O'Donnell talked about it, but she stopped. She kind of acknowledged it, and we tried to get her to campaign for the AHA, and she just wouldn't do it.
California ACC is here to support any sort of, platform or something, or any celebrity steps up or something, or social media. We'll be happy to partner. Yeah.
And for Christina, one last question. For those women we have with preeclampsia or eclampsia who come in, who are going to have a lifetime increased risk, does treating their blood pressure and other risk factors get that risk eliminated, or is there an unknown factor in preeclampsia that continues even if we treat those obvious risk factors?
Yeah, that's a great question. It seems to be unknown because the incurred risk after that presentation during pregnancy or even beforehand seems to really last in the decades that follow, and they're much more likely to need ongoing treatment for hypertension and have other cardiovascular diseases. So actually, the newer recommendations from ACOG are that all of the patients with eclampsia should be started on a baby aspirin. We don't know how long that recommendation is for, but they should be on a baby aspirin and should have their blood pressure aggressively treated. And I guess the hope is that if that's initiated during pregnancy, then hopefully that'll be our opportunity to connect them with the medical system and continue that prevention measure throughout their lifespan. But I think that they're often lost to follow-up still.
I want to say something on a hopeful note, which is that in the graphs behind me, when we started working directly with medical groups to show them what their data was for hypertension, lipid control, and blood sugar control for patients that had already been identified for needing to be on those therapies, we saw in the aqua graph, which is women, a very rapid decline in acute myocardial infarction, hospitalizations compared to men and compared to the state. And part of that was because I was telling my story of having lost my mother at such a young age and in such a shocking way, with hypertension being a silent killer and women being the ones that take care of their families, but they don't take care of themselves. And Steve Chen and I share, family stories. Many of us share family stories, which I think need to get out there more. One of the other family stories is I have a sister-in-law, a nurse at Kaiser, who died of a stroke, even though she said at age 35, I'm having a stroke, and they would not listen to her. And so listening to women's stories around cardiovascular, I think, is just so important. And you see how rapidly we dropped the acute myocardial infarctions by raising the awareness among the medical directors and urging them to take action with their women patients. So I do think there are things we can do with public policy, and we should probably get to a stage of gloves off here, where really if the medical groups are not following the guidelines, we've been really nice, but honestly, shouldn't there be lawsuits if women are not getting the therapy that they need? After all the years you've been working on this, Dr. Bairey Merz,
Yeah.
Dr. Mijalski, all of these great women leaders that we have with us, and all of the cardiologists that are aware of this. The problem is primary care is where people are being seen. And really, for women who had the indications of during their pregnancies that they needed to be followed, isn't there something we can do there? So I don't mean to be on my soapbox, but I do think we should be trying to get Dr. Balmer to think about, how do we seize this legislative opportunity to yield some of this surplus in California to do some of the things? And part of that is the sort of table that you were talking about, Dr. Bairey Merz, where there really isn't awareness about breast cancer versus heart. I tried to establish such a table, and I was told by some cardiologists, we don't want it to be a competitive thing. On the other hand, just straight numbers comparing breast cancer to cardiovascular, I think coming from the ACC might be super powerful.
Well, I really appreciate your advocacy, and I think those figures in the background are pretty amazing, and kind of similar to that ACS data that I showed, that when they just put in programs, they put guidelines into place, they saved women's lives. So I would, continue that. At the NIH, if we don't have an appropriate response to are women included, are racial, ethnic minorities included, and are you treating sex as a biological variable, you don't get the money. You don't get the grant. And so instead of it sort of being a carrot, which is what the UK did, right? If you didn't do the diabetic screening, if you didn't check their feet, Rand helped them with this like 20 years ago. And I don't think it was that successful. The docs just were sort of doing this busy work. But if there were penalties for not hitting quality marks, isn't that already happening?
I think that's where we should be going.
Yeah.
But perhaps they're not there for sex differences yet.
Yeah.
All right, well, we're nearing 6:15. I think we should wrap it up, even though I think there's so much more that we all could say. Hattie, does that sound good?
Thank you for this wonderful leadership, and let's stick together and do some things in writing. Dr. Balmer, would you do the wrap on the meeting?
On behalf of the Right Care Initiative and the people of California, we want to thank our two excellent speakers today for a comprehensive and thorough review of the information. And at this time, I would say there is hope, and where there is hope, there is everything. So have a great afternoon, everyone, and we'll look forward to continued education improvements and trying to spread this out across California. And I hope there is a light at the end of the tunnel for all of us and our patients. So on behalf of our co-hosts, thank you very much for excellent presentations, and have a great evening.
Thank you.
Thank you.
Wonderful work you're
Thanks for
doing.
having me.
All right. Have a good
Thank
evening.
you. Bye-bye.
Bye now.